Thank you for coming this morning. As I saw, there is a lot of people from abroad, so I will give my lecture on English if you like that. Before start with complication of hysteroscopy, I must remind you about one procedure, hysteroscopy, that first comes as a diagnostic procedure, then there appear diagnostic and operative procedure, and most severe cases we done with this procedure, and now it's moving from operation room to office room. And there is a huge, expensive, maybe critical use of this procedure, and even it seems it is minor surgery, but from potential complications point of view, it's a major surgery which can have some surgical problems and complications. And first of all, even in 19th century, when first hysteroscopy was done, there was reported a complication, and that's why we must register all complications. We must scope and report every complication we have to have our database. And to avoid the complications, we need a good learning curve, good case selections, adequate preparation of patients, and use of good distension medium as well as equipment. We have a classification of Royal College to 3 levels of which we done hysteroscopy, and severe cases come in third group as Asherman syndrome, then myomas, mucosal myoma, one and first and second stage, and complication rates is low. It's near 5%, and this is the same as the laparoscopic complications. But also new studies show us that complication from office hysteroscopy is the same like inpatient hysteroscopy. But when we look for severe complication, laparoscopy had more moderate and serious complication, while hysteroscopy had a light and maybe little moderate complications. There is a lot of potential complications from perforation, bleeding, electrosurgical complications, then infections, from medium, position, and other. And classification is based on numerous criteria. It can be early, late, diagnostic, operative, then perioperative, intraoperative, postoperative, as well as by the position, by anesthesia, then early and late complications in the other. Diagnostic complications is from office hysteroscopy, and the important is vasovagal reaction. And if we have that reaction, we must put patient in Trendelenburg position, but it is we must always go before dilatation with ice control through the cervix. So we don't need to dilatate first cervix before starting. And there is uterine perforation, infections, bleeding, and cell dissemination. Also, there is operative hysteroscopy. They are too rare, but some of that, there is reported some death case from operative complications, but perforation is most usual, and that's why it's always from resectoscope. That's why before we start doing with resectoscope, we need to first start with diagnostic hysteroscope. Then there is fluid overload, bleeding, embolism, anesthetic complication, as well as burns. This is show which complication we can have. And incidence of complications, it depends of experience and of complexity of cases. From experience, the number of, it's a rare complication and the number decrease if the center have 500 and more complication hysteroscopy done per year, but while it decreases if we have severe case like Asherman resection of septum or myomas. This is shown in this table, and in one study there is over 20,000 patients. We saw that what I'm talking, that most severe complication is from resection, seen here, and myomas. Also, second classification, we have complication from patient positioning. There is reported nerve lesion, then depending procedure duration, and we don't need to tolerate discomfort of patients. Then gas embolism is another complication. It is potentially fatal, and origin of embolus come from room air, from gas-based distension, or they can be without expressed symptoms. But the most important thing is when you're doing hysteroscopy, never put a patient in Trendelenburg position. Why? Because the gas enters the cavum either through the distension system or transcervically, uterine, or other blood vessel which is due to the dilatation, multiple introduction of the hysteroscope. Then, if we have gas embolism, what should we do? First of all, stop operation, then put Hager dilatator to do cervical tamponade, then vaginal tamponade, put patient on the right position, give patient 100% oxygen, put central venous catheter, and did CPR. The uterine perforation can be during cervical dilatation or during surgery, and this show table that Asherman syndrome is most for uterine perforation. How can we prevent that? We can prevent, we can use complicated cases done by eye control or ultrasound or laparoscopy. Then we need to activate the electrode only when we are in the certain position, and Asherman and G2 myomas only should need only a person with good experience, and if we have seen here the septum, we should cut only with scissors. Fluid overload, distributing factor is the distending pressure, operation duration, type of operation, bleeding blood vessels is distension media. If he had fluid overload, we need to stop the operation to force the diuresis and measure natrium and give him adequate therapy. Absorption mechanism for fluid overload is intravasation, transtubal loss, and uterine perforation. And prevention of the fluid overload is to use bipolar instruments, to use low pressure, then operation to be well controlled. If we have blood vessel more than 500 microns, then we need to coagulate them. And for each liter of medium lost, we must pay attention. And we need to stop operation if the loss in the, if we lose 1 liter of non-electrolyte solution and 3 liter of electrolyte solution. But 2 or 3 months ago in our clinic we have 2 cases that woman lost only 1.5 liter of electrolyte solution, and we have a pulmonary edema. So it depends of case to case. Then bleeding, it can be uterine or cervical, and uterine, it is during or after operation, and if it is uterine bleeding, it stops spontaneously. But post-operative for cervix, we need to put compression or ligation. If it is uterine bleeding, then we have to give uterotonics or tamponade uterus. What about infection? Infection is said to occur characteristically within 5 days after procedure, and it's characterized by triad of symptoms: fever, pelvic pain, and vaginal discharge. But use prophylactic Cochrane studies said that we don't need to use prophylactic antibiotics for this procedure because there is no benefits of antibiotics prior to transcervical intrauterine procedure due to lack or high quality evidence. And this table shows that there's different with the group who didn't get antibiotics and who get. And considering the low risk of infection complication after hysteroscopy, we don't need routine antibiotic prophylaxis, but if we have a patient with history of pelvic inflammatory disease, then we need to give them antibiotics before operation, and if you expect that operation will be prolonged. Also, it must be a careful selection of patients. Late complication is uterine rupture in pregnancy. In most cases, it happens after use of the stethoscope, and it is not. It happens because when we do metroplastic, we don't report every time that we have a perforation, and then when she becomes pregnant, it comes to uterine rupture of uterus, and it can happen in early stage of pregnancy, but also, as you say in this picture, it can happen in 29th week of pregnancy. But it is very rare complication, as this study shows, only 0.82%. Then synechia is also late complications, and it can. We must recognize this complication and use after operation estrogen, then barrier substance or EUD. Also, there is new studies which show that when we have synechia, it's better to use scissors versus electrosurgery. Instead, when we talk about monopolar or bipolar stethoscope, of course, bipolar is better. And how can we avoid complication with good preparing patients? I don't talk another, but in these days, 3D ultrasound is best thing what we have, and prevention of complication is good diagnostic by ultrasound. If we did 3D ultrasound, we will see how far septum is from fundus, and then we don't need to do MRI, ACG, laparoscopic to see how deep is septum. And this is a case 5 days ago in our clinics. We done 3D ultrasound, so septum, so how far from fundus. Then we can easily did intervention, and we go near internal ostium of lupus. So in conclusion, education is very important, and we must follow protocols. We must have mentors, trainers, learning curve. Of course, protocols is most important, but instead of conclusion, to repeat, follow the procedure. It is safe, but potentially serious complications. Hysteroscopy has specific risk related to mediums and surgical equipment. Then experience and type of procedure. Always do diagnostic hysteroscope before stethoscope. Then use smaller instruments with eye control. Use bipolar instruments and have good education. What can we more do to avoid complications? Maybe for myomas G2 and G3 is to use radio frequency ablation, and these days we are getting on our clinic radio frequency instruments. When we will start transvaginal radio frequency ablation of myomas for G2, G3 myomas, so that's how can we avoid complication of these severe cases. And of course, every balance of efficiency and safety is a key to life. Thank you for your attention.